Good morning, everyone. A warm welcome to our UCT-Africa virtual meetings. Thank you again to everyone that's joining us. There's just one or two more people that are still joining, so we'll just allow them into the waiting room. We're very excited to be able to host the PENTAFRICA initiative this morning. We've got presentations from our Zimbabwean colleagues, Clemence Chidziva and his team. Before we start this morning, we'll also just ask Prof. Pierre from UCT Red Cross just to say a brief word, a little bit about PENTAFRICA, and also maybe just to give a brief introduction to Clemence. Clemence, we are privileged to host you. We look forward to a good meeting. I'm going to be sharing the slideshow that they've prepared from this end, so just bear with us if there are any technical difficulties. So without further ado, I think we should get the meeting started. Prof. Pierre, are you on the call? I will hand over to you if you're ready.
Hi, Louisa. Good morning, everyone, and Clemence. And I see that Cameline is also online. Welcome. Thank you very much for joining us on this early Friday morning. I also want to welcome everybody who's attending on behalf of PENTAFRICA. For those of you who don't know, PENTAFRICA is Pediatric ENT in Africa, and it is the African Pediatric Society that was started in 2018 that Clemence was actually instrumental in setting up with a very well-known pediatric ENT surgeon, Dr. Peter Coltide from Stanford. I just want to say one thing about Clemence before we proceed. Clemence actually is quite a dynamic figure in the field of pediatric ENT as well as general ENT across the continent. He is currently working in Harare. He was actually working at Harare Central Hospital, but way before that, he did his ENT training at University of Cape Town. I'm not going to say how long ago, Clemence, but that was at the University of Cape Town under Prof. Fagan, and then went on to start at Harare Central Hospital. And then he actually pioneered the postgraduate program in Zimbabwe. So he's a dynamic figure and also is started off as an educator almost, as well as a person with clinical and service delivery. So we're actually very privileged to have him join us and to be a part of the pieces of PENTAFRICA when it started. And also, I think he has since left the university post, but his legacy still continues and he's still an active part of that program. So without further ado, Clemence, I'm going to hand the platform over to you to share. And thank you very much for joining us today. We're excited to hear about what you're going to talk about. I'm going to mute.
Okay. Thank you so much, Tasha, for all those great accolades. Thank you, colleagues, for allowing us to share some of the work that we're doing around ENT hearing healthcare in general, but pediatric ENT hearing healthcare in particular. Like Shazia has alluded to, I actually wear a lot of hats, but one of the things that I've been concentrating on over the years is to see an improvement around ENT hearing healthcare. We then also find that for pediatric ENT and pediatric ENT hearing healthcare within Zimbabwe and within the region, there's quite a few challenges, but at the same time, there's a lot of opportunities around pediatric ENT hearing healthcare. So today we're going to share our work with you. We start off with what I call a situational analysis. Where are we and what is happening in Zimbabwe? And then we will share with you what we are doing to try and improve pediatric ENT hearing healthcare in our country. And we will share a few of the challenges and opportunities that are available in this field. You can go to the next slide. So that is pretty much the outline of our presentation. To go through this presentation, I'm going to be helped by two of my colleagues. I've got Dr. Ruvimbo Ndwenge. She's a recent graduate from our MEd postgraduate program, and she's working with me very closely in all the work that we do around ENT hearing healthcare. And she's also got a particular interest in pediatric ENT. So she will give the first part of the presentation. The second part of the presentation will be done by our head of audiology, Tinashe Nopara, who will take us through the second part. And then we'll open it up for discussions after that. I understand that Jessica will take 5 minutes of a slide presentation once we've finished our presentation. So now I'm going to hand you over to Ruvimbo to take us through the first part of the presentation. And you can give us the next slide, please.
Hello, everyone. My name is Ruvimbo Njenge, as prior introduced by Mr. Chidziva. So our talk is generally on what we are doing in Zimbabwe, what we want to do, and what we've already done. So in general, there is a general lack of awareness regarding ear and hearing health issues in sub-Saharan Africa, including Zimbabwe. Our communities have reduced awareness due to lack of promotion or engagement of the health ear hearing care community to our communities. So traditionally, our communities used to have their methods of managing ear and hearing problems, which may ultimately sometimes cause ototoxicity or actually worsen the condition of the patient. And it's our mandate as the ear and hearing care health givers to engage our community to improve their awareness on the conditions that are available, on improving their knowledge on prevention of disease and identification of ear and healthcare problems. And also, utmost important is for them to know where to get help and what help they can actually get. Because sometimes the community identify the problem, they know the problem, but they're not sure where they can get help. In our country, there has been a paucity in the ear and health care providers in the peripheries where most of our communities are, where most of our patients are. Hence, patients may actually go to the hospital, but actually don't get the appropriate care. And on that, we've been working on to try to make sure that ear and health care is available, especially to our pediatric population. So we've been trying to improve awareness through community engagement, ear camps in our district hospital and in our provincial settings, provincial and rural settings, to have health talks on radio, on TV, advocate for hearing through World Hearing Day campaigns, use of posters stuck in schools, in hospitals, in community halls, and on leaflets that we can give to patients when they come to our clinics and when we visit schools. We also had a patient-to-patient communication, For example, a patient from the peripheries or from the deep rural spaces visits my clinic. I take it as an opportunity to advocate to them what services are available and what where services can be sought, even for the condition that they've not actually presented with. So for years, raising awareness in hearing healthcare has been a neglected priority in most of our health centers. And also, utmost is involvement of our government and policymakers and NGOs, which need to be targeted through effective advocacy. As we also do that through healthcare professionals in the community at large. So on the slide background, there is actually lack of awareness among health professionals at large, from the grassroots, from the community health workers, up to even some specialists in other specialties, for example, in pediatrics, in maternity, or midwives. We need to improve teaching in our curriculum for undergraduate medical students, our nursing diploma of nursing students, such that after they finish their training, they've got a capacity to manage urgent or minor ear and healthcare problems, and also identify patients that need to be referred. The workshop for doctors and nurses is work in progress. We're actually doing workshops in the districts and provincial hospitals to make sure that our nurses and doctors, who are the first port of call in the districts and provincial hospitals, can, number one, identify ENT healthcare problems. Number two, treat those that they should be able to treat. And number three, refer those that need referrals early on time. We also have combined lectures in our tertiary institution with midwives and pediatricians and neonatologists to advocate for early newborn hearing screening, or for them to at least refer a targeted population of pediatric. So early referral plus management of simple conditions should be actually done at grassroots level. Next slide. So all these things that we've been talking about actually lead to a delayed diagnosis, which we actually see nowadays. But with all those maneuvers that we've been trying to do, there's actually been an improvement in early diagnosis of patients. Number one, with hearing problems. Number two, with ear problems. On that picture, you can actually see that there is of late referral of a patient with a discharging ear who actually presented now with mastoiditis or a mastoid abscess. So the same actually happens in our newborns who are not screened and may present even at 5 years of age, and will be forced to do cochlear implants even at a later age, like 5, 6 years. Next slide. So universal newborn hearing screening is when you screen every newborn for hearing at birth. So this is currently the world standard, but in our sub-Saharan Africa, especially in Zimbabwe, this has not been available to all our newborns. Currently in our country, there is no mandated or formalized or standardized implementation strategy. A pilot study was done at our one of our tertiary institutions, Ross Central Hospital, about 3 years ago, where we tried to implement newborn hearing screening in all our babies born in our maternity unit. But we met a lot of challenges, which ultimately led us to stop the project. So the problems, hindrances were from everywhere. From structural problems, we couldn't find a quiet room in the maternity unit, and only quiet rooms were available about 200 to 300 meters away in our ENT clinic. Hence, mothers would actually opt not to come there because it's actually a increased journey, unlike if we'd found a quiet room in the maternity unit where they just come from their room, which is admitted, and just go down the corridor to a quiet place. Also, logistics. If you actually need to be screened, let's say we screen every morning, then it means that a patient who was supposed to be discharged in the afternoon or in the late in the evening has to wait for another few hours for their baby to be screened. Hence, most mothers and most midwives will actually say, you're not causing overcrowding in our wards. The mothers want to go home, and that was actually a logistic problem. Also, manpower. We've seen that our hospitals have been struggling with adequate manpower for whatever the work that has been available. Now we want to add some more work either on the midwife or on the rehabilitation technicians who are doing the screening, and manpower was a problem. Also, the community resistance. This is a new thing that has been introduced. Everyone thinks that their baby is normal. They don't want any abnormalities to be identified to them as early as that. And the community thinks, oh, this is not a good problem. So this has to be addressed through community education and working with the community to appreciate the need for newborn hearing screening. But still, we are doing targeted screening for those babies who have been in nursery, those with jaundice, the meningitis, long staying in ICU, who have been on oxygen therapy for some time, but still are still facing a challenge on those who actually need targeted screening, as they need to come to our ENT unit from the maternity side. Though it's still work in progress, we are working on advocating for every child who needs at least targeted screening to be screened. Next slide. School hearing screening. So if we have failed at newborn hearing screening, we can still try to target those children while they are in primary school or even secondary school. We've been currently doing workshops or outreaches where we visit schools to do hearing screening, as the Ministry of Education and the Ministry of Health are still doing talks to implement the strategy that we have all children entering school to be screened at their entry point. Like our first grade is their ECD. So all ECD students should be screened for hearing before they join school. That's our plan. But we've been in liaison with the Ministry of Health and the Ministry of Education, and that has not yet come to fruit. But currently, we are actually doing hearing screening in some schools, a few schools, especially the remote schools that will actually benefit. And that picture shows us doing hearing screening in a makeshift audio room at school. And actually, some students, those are even high school students, benefiting from hearing aids even at that later age. Currently, targeted screening is done in schools for the deaf, as those we actually note that there are some kids who are not in mainstream schools who actually have to be in mainstream schools. Probably maybe they've just a ear infection which need to be managed, or some conditions that can be managed surgically. Even those that can actually benefit from hearing aid and their hearing level come to closer to normal. Next slide. So delayed access to services and intervention in our public institution. Of note, we have a inadequate number of ENT specialists, inadequate number of audiologists, inadequate number of ENT trained nurses to offer services in most of our public institutions. Hence, there is a large queue of backlog of patients who, even after being referred, have to wait for some time to be seen in our outpatients clinic, which are almost always full. Also, because of the COVID pandemic, some staff has been shifted from our basic or our general outpatient work to work in the COVID unit, hence worsening our staffing scenario. Although sometimes patients are referred fairly early, there is also poverty in our most of our patients, which actually delays the patients from coming to our tertiary institution, which offer ENT services. Of note, in Zimbabwe, most of our ENT services are centralized in the major cities, Harare and Bulawayo, with a minimum ENTs. We only have 2 ENTs in the peripheries, but the peripheries are actually less than 100 kilometers away from the Harare, where we have most of our ENT specialists concentrated. So this all will lead to delayed access to service and intervention, especially in our public institutions. Next slide. Locally, we have no training programs. We didn't have training programs in audiology, in speech therapy in our country. With the recent introduction of audiology and speech therapy BSc honors at the University of Zimbabwe, we currently have no graduates yet. We expect our first group to graduate in 2022. Hence, all the audiologists that we have in the country, we have 8 audiologists and 8 speech therapists. All of them have been trained outside the country, and they to come back home to offer services. Besides that fact, of the 8 audiologists, only 1 is available in our government institutions, and none of the speech therapists are available in our government hospitals. Of those speech therapists, all of them are concentrated also in the cities. Hence, there is a paucity in the peripheries. Next slide. Training of rehabilitation technicians to provide ENT and audiological services has been done in our country so as to bridge the gap of lack of staff So in our district hospital, we have rehabilitation technicians who are responsible for physiotherapy, and also we have sort of added a lot on them to manage our ENT and hearing services in the peripheries. So trainings have been done periodically, yearly, with refresher courses, and also follow up in the district institution on their in their workplace to make sure that they are doing the correct thing. These rehabilitation technicians are doing a lot of good work for us, especially screening patients, managing minor conditions like EFN bodies, acute infections before referring patients. We actually have them doing also offering audiological services, doing hearing screenings, and even offering hearing aids in the peripheries. We equip our support with CBM. We actually equip every rehabilitation technician before they go back to their station with at least a basic kit with their otoscope, their headlamp, their the things to use for ear stringing, and also in working audiometer, which are regularly serviced so that they can actually implement their duties in the peripheries. We also do trainings for community health workers to identify patients with ear and hearing problems in their community, as they are the first port of call for patients in our health structure. So the village health workers are actually taught when to suspect ear and hearing problems and where to refer. They also help us in follow-up of those patients and many patients to come for follow-up. So our training programs have been going on well. Those are pictures showing us doing a hands-on training in Harare, and also giving lectures. Next slide. So where are we today? So this is the question. This is what we want to do. We know where we are heading, and that's what I've presented is the present scenario in our settings. What are we going to do about this ear and hearing healthcare in our Zimbabwe? Let's have the next slide. We have started in ENT training in 2016, and of late we have 4 graduates, of whom I'm the newest graduate. The training is continuing with our local university, with support from non-governmental organization, also support from our friends from UCT and from Australia. And our training program has been running well. We hope to retain most of all of the graduates that we produce. Next slide. We've also started a BSc Honors in Audiology and Speech Therapy program, which started in 2018. And we expect our first graduates to be in 2022. We have now 3 streams with a total of about 60 students. We also anticipate to enroll about 30 students this coming intake, September, October, UZ intake. And we hope to retain also the audiology students. But our main challenge for the audiology and speech therapy students after our training, we don't have a post for them to work in our government institution, but we're actually lobbying our government to release posts for them to be able to be absorbed into the public system. Next slide. We are very thankful for our supporters, the with ENT CBM, for building a state-of-the-art ENT audiology and speech therapy unit at one of our central hospital, at Harare Central Hospital. The pictures they show our unit. We have 2 consultation rooms, we've got procedure room, we've got a speech and audio room, we have a speech therapy room, and a state-of-the-art audiology center. We are also still work in progress. You can see those men in hard hats. We are building 2 ENT theaters to complement work in our clinics. Next slide. Our challenges. So from 2019 up to 2020, our health systems faced a lot of strikes with government workers advocating for good working conditions and better remuneration, better care of the patients. This actually set our work back as our clinics had to be closed during the strikes. Next slide. COVID-19 gave us challenges and opportunities. On the slide there, you can see our PPE when the COVID pandemic started versus our current PPE now available. Hence our clinics and our theaters and even our casualties seem to actually went on slowdown because of lack of PPE, but actually COVID-19 gave us a lot of opportunities as now the healthcare system is now given a better chunk of the budget, and the government is actually now aware of the importance of our healthcare systems. Hence, probably maybe in the future, we may get a better support in our units. Next slide. Our major challenge is human resource limitation. Of note, in Zimbabwe, as I earlier on alluded to, we have 8 speech therapists, 8 audiologists, and about 15 ENT specialists, of which less than 10 of those are in our government practice. We are still working tight to try to improve our staff, especially the audiologist, the speech therapist, and the ENT specialist. So I will hand over to Tinashe, who is going to discuss more of our cochlear implant journey. You can go to our next slide.
Thank you so much for the opportunity to give us the platform to share our journey with you. So just like with any journey, it comes with growing pains and some stretching that we go through until everything is in place and working well. So our journey started in 2016, and to date we have managed to implant 14 patients, the majority being pediatric with 2 postlingual adults. And as you can see, or as you know from Dr. Chidziva, we've also rubbed on the passion for dealing with pediatric population. Hence, they've been our main targets all along. And in an ideal scenario, you'd want to start a cochlear implant program when there are certain structures and resources in place. But for us, it's something that really wasn't a luxury, and we had to start with what we have, and then to where we are now. You can move on to the next slide. So this is a picture of the recent surgeries we did in April this year in our very beautiful new theaters that were established in 2017. So when we did our very first cases in 2016, we used the public institution theaters, and then from then on, we've been using our theaters, the HINT, Harare Eye, Ear, Nose, and Throat theaters. You can move on to the next slide. So this is the breakdown of the cases we have been doing over the past years. So the ones we did the surgeries in April, we did 3 cases, and we are looking into doing more early next year. Though we have lots of patients who are actually candidates for cochlear implant surgeries, but the main issues have been finances. So we actually had about 3 cases we wanted to do this September, but because of financial restraints, we now have to push those to next year, and hopefully everything will now be in place. You can move on to the next slide. Okay, so to touch on some of the outcomes we have had to date, the easy ones were the adults that, sorry, can you just go back? Thank you. So the easy ones were the adults really who were postlingual, both were postlingual cases. So the first case was a female in her 50s, and she was a teacher by occupation. And the second case is a male in his early 30s who got hearing loss due to occupational noise exposure. And in the cases, the company managed to fund all the procedures to date. The rehabilitation then was also short, and they were discharged quite briefly, and the benefit obviously was immediate. And then from our pediatric pool, we have an unlikely success story where it was a child we imparted at borderline age, which is 5 years. We actually didn't think she would be the best candidate, but what we have noted is the consistency from the family in supporting the child that has made her be such a success story, to a point where she's been getting awards and prizes throughout her kindergarten and her ECD school. And she even can be quite independent, and was a mini bride at a wedding, blending in with the others throughout the day, that if you're not up close to her, you wouldn't know that she's a child who's hearing impaired. This is despite the fact that even after the journey, the parents still split, but they've been managing to be giving consistent support to the child. Then the other second success story is one that we've actually just done in April. This is a prelingual child, but the progress that has already made since the switch on, which is like a month or two now, is quite remarkable. So we're really looking forward to what we're going to see from the child. And then there's an interesting bit, and we did implant a child who was 13 years of age, had meningitis when he was 9. So we really thought we would find ossification, but there was really minimum ossification found. So we managed to go out with the implant, and a benefit had been noted as well from the family. You can move on to the next slide. So with any program, there will always be things that happen to stretch us and to pull us one way or the other. And our very first one was from the first batch that we did. So this was a child, perfect age, 2 years. I think we implanted them by the age of 3. Young parents, educated, very good support that we thought. Medically, everything else really was pointing to him as a star patient. So we managed to do the surgeries and the switch on, but afterwards, nothing really happened. And I think that was a big blow to the parents with the unmet expectation, and it was also a big surprise to us, which then led us to ask the question, what did we actually miss in this case? So in trying to solve what did we miss, we had to include a neurodevelopmental pediatrician just to check if there's other things that we could have missed. But because of now the unmet expectations, the parents went into another cycle of, I can say, maybe grief or denial, and didn't want to do anything at all to try to solve the problem. And then that also added pressure to their marriage, and they also got separated. But unfortunately, with their case, it led to that impacting the support that the child needed for therapy. So when they had to bring them in, and then the other parent to say, no, I thought the other one's bringing them. And so it's been quite a difficult journey trying to just get them back on track and see how much progress we can get. So this then brings in the issue of the opportunities that are coming out of some of these challenges that were faced along the way. So the first, like I mentioned, is now we saw a need of roping in a neurodevelopmental pediatrician right from the start, so that we just check everything, all the pathways, just in case there's something that might affect the outcome of the surgery and the progress thereof. And because of the issues that have been coming in with some of our parents, that you find that pre-implantation, you explain everything, they have so much energy, they are ready to go, ready to do everything. After you've done the surgeries, now you want them to really have the same energy for consistency in therapy, rehab. And then they start coming up with stories, some which are valid, some which are not so valid. So we found the opportunity of dropping in again a psychiatrist, but even including them right from beginning, so that way, if some of these challenges come up along the way, it will not seem to the parents or to the family that we are suggesting they have a problem, and then we will be able, hopefully, we'll be able to work out all the links and to be able to give full support that the patient will need. So some of the other learning curves that we have also found is considering a really stricter candidacy. So not just on the medical issues, but just the financial and the social aspects as well, because also with the financial aspects, even if some may get funding to have everything done, but the maintenance that's needed for batteries or replacements for cables afterwards, if they're not able to sustain that, they using the processor, which defies the whole process. And now we might need to focus our strategy and target maybe post-lingual population, just so that we boost our number of success stories. So that way it will be easier to approach stakeholders that might help with funding, as well as our medical aid funders, because they're still trying to understand what this whole cochlear implant is and how much of an impact it can have on the patient. So I've already touched on the issue of psychiatry. You can move on to the next slide. So it really then just brings us to the question, as a young cochlear implant team, that, you know, what should we be doing to have an impact? And we'll really be willing to learn from everybody else, your input and your direction with this regard. So I'm gonna hand back to Dr. Clemence, and then we will close out.
Okay. Thank you so much to Ruvimbo and to Nashe for taking us through there. And as you have seen, I've got one motto, why I love working in Africa. I always tell people that there's absolutely no challenges working in Africa. There's only opportunities. Opportunities to grow, opportunities to do things differently, and opportunities to think outside the box and make an impact. So when it comes to pediatric ENT healthcare, there is plenty of opportunities for us to collaborate and make an impact. Thank you so much. I'll hand over back to the chair, I think Shazia, to take us through. If there's any questions, we will field them.
Hi, thanks so much, Clemence. What an excellent presentation. Sure, I must say you guys have really done so much, and I look forward to seeing where this goes. It's really a testimony to how much one can do with the minimal resources. Good luck with everything, and of course, we're now part of the history too. I'm not sure if we have time, Louisa, but maybe is it possible to get Jessica to do her presentation and then we do questions after that? What do you think?
Yeah, sure, Shazia, no problem. Jess, if you would like to share your screen, I'm just going to stop sharing the previous screen, and then we'll take questions after.
Thanks. Clemence, please stay on, and your team. Thank you so much. What a lovely presentation.
Jess, we can see your screen. That looks good.
Thanks very much, Clemence, and your team. I think you're doing amazing things, and it's so amazing that you've been able to do it with limited resources, but also that you're so humble about it. Thank you for this opportunity to allow me to present this project that I'm proposing. Hearing loss is the 4th leading cause of years lived with disability worldwide. And it has an enormous economic and personal consequences to the individuals who are affected. And sadly, the vast majority of people with hearing loss live in low to middle income countries, where, as we've seen, there is a severe shortage of skilled ear and hearing health specialists. It's been reported in Africa that there is less than 0.1 ENT surgeon per 100,000 population. And to put this in context, the United Kingdom has 10 times more ENT surgeons for an equivalent population. Worse still are the shortages of audiologists and speech therapists, which has been reported to be 357 times and 2,500 times less than the United Kingdom, respectively. And despite these dismal numbers, as we have just seen in the presentation before, there are many excellent African ENTs and hearing health professionals who are providing remarkable services considering the challenges. So what we would like to propose is to try and find African solutions for Africans. And Clemence is far more qualified than I am in this regard and has kindly included me in an African ear and hearing health forum. And it is so reassuring to see how many like-minded people there are out there. But for us to work out a solution, we need to quantify the current situation, and we need to officially document the challenges, identify areas for research, identify shared problems for collaborative solutions, and then we need to track the progress. At the moment, there are so many excellent people working in silos, and collaboration may not only ease their burden, but it will also mean that their actions can have far more reaching consequences. So the WHO has this ear and hearing care situation analysis tool, and they have given us permission to develop this tool into an online registry. And what this means is that it will allow us to, the easiest and most user-friendly way to document these challenges. And what we would like to do is to include as many countries as possible. And to start with, we'll just complete section 1 and 2, but, and this is crucial, it is for the people involved who, it is going to be labor intensive initially. So whoever is interested in the project needs to be properly invested and needs to want to follow it through. Section 1 really is just a population profile of the country and the socio-political profile. And most of these things are sort of available to, widely available in most countries. It also has health status indicators so that you can sort of get a judgment for the current health status in the country. And then it also has hearing loss prevalence, the incidence of early childhood and congenital hearing loss, and the main causes of hearing loss. And these are potentially problematic because there may not be epidemiological data for a lot of the countries. And so it might be anecdotal sort of numbers or as much evidence that as we have, and it allows us to plan intervention and proper epidemiological studies going forward. And then section 2 is an assessment of the health system capacity. And why this is so important is that if you don't know what your health system's current capacity is, it's very difficult to change policy and advocate for funds and improving policy going forward. And then section 2 also has numbers of the health workforce. And what that is quite nice for is that it's important for us to know who are our allies in the country and who we can collaborate with. So this it's not only it's also a networking project, which will be quite nice, I think. So we really feel that this could be the starting point of a wonderful collaborative partnership with many countries. And we really hope that there are people out there who might be as enthusiastic about it as we are. At the moment, we're just trying to drum up awareness for the project and to advertise the project and hopefully get as many people who may be interested as possible. But we're only going to implement the project in November. Thanks very much.
Thanks a lot, Jess, for sharing that and for creating awareness. And also a special thank you to Clemence and his team for enlightening us and sharing their successes as well as the opportunities they have there. I'd now like to give opportunity to the floor for any questions or comments. I know that Dr. Sanchez Harris might just have some input with regards to your lovely cochlear implant program. Sanchez.
Thanks, Clemence and his team. That's a really nice presentation, and I think very well, inspirational, really, to see what can be done with very limited resources. Yeah, it's always been fraught with challenges starting a CI program in an emerging or developing country where resources are very limited. But as you mentioned, Clemence, it can be done. I think the main challenge has always been, well, firstly, I think I have to, sorry, I forget to name your speaker who did the first presentation. I do apologize. But I have to commend the fact that you guys have started from grassroots up. And I think it's important that for any cochlear implant program to survive, you really have to look at overall hearing health and ear health. Instead of sort of going right to the top and starting with cochlear implant and realizing that it isn't just, it should really be the cherry on top. And you can't really start a CI program unless you have addressed all the other hearing and ear issues that there are in the community. I think ethically, that is the right way to do things, and you've done that beautifully. We don't really have universal screening in South Africa either, and I'm not quite sure why we don't. I think we certainly have enough audiologists, but I think there are sort of pockets where where screening gets done routinely, mainly in private hospitals, in some hospitals, state hospitals, but certainly not across the board everywhere, which I think is very sad. And like I said, I don't know why that is. I don't have an answer for it. I think, I'm not sure Silva's on the chat at all. I think one of the problems that we face with in our country particularly, because of lack of universal screening, is that our patients often present late. And in fact, even with a postlingual deafness, even the adults present late. You know, an adult who presents after 10 or 15 years of profound hearing loss and not being, has had no sort of amplification at all, one can't really implant, is not going to get a good result. And I think, as you quite rightly pointed out, sadly so, we've always been competing with other interests like TB, HIV, trauma, cancer, etc. And with COVID, we've just been pushed further and further back into that queue. But I think it is important. Sorry, the other thing to mention is just, I think the other thing that you've done quite nicely and demonstrated quite nicely is that of educating community, because I think there's a huge amount of progress that can be made just by making people aware. I think awareness is really where it should start. And I think if Silva is on, I think one of the problems with the universal screening is, I think patient or parent education and parent awareness of hearing loss is an issue. And if we don't quite understand it, you're not really going to be good with the follow-up and the follow-through or realize how important it is. So, I mean, I have to commend you guys. I think you've done an amazing job. I think it's going to be quite exciting to see where it all leads to. Yeah, very nice presentation.
Thank you very much, Dr. Harris. Dr. Zubair Khan, you've also got your hand raised. Please unmute your microphone and make your comment.
Hi, thank you for the nice presentation. And can you hear me?
Yes, we can hear you loud and clear.
Okay, thanks. So yeah, I'd like to congratulate the Zimbabwean group on the excellent progress, you know, with the surgery. Also, I'd just like to inform the audience that earlier, I think this year, we, myself, Professor Shifilaro and St. Meyer were part of a Pan-African endoscopic ear surgery group that was formed. And the endoscopic ear approaches also may, help with the middle ear diseases in certain conditions. And certainly some of our colleagues, like in Malawi, have been able to offer quite a lot of service to the general public and been able to train people to do myelingoplasty and things using the endoscope with encouraging results. So that's also something we need to keep in mind. And I'll just post my email address on. If anybody is interested in this, the endoscopic ear surgery part, so far we've run a few courses in South Africa, in Pretoria, Cape Town, in Stellenbosch, and at UCT. And if there's anybody wanting to have assistance with the endoscopic approaches, you're welcome to contact us for some help. Thanks.
Thanks very much, Dr. Sibere. If you can just post your contact details in the chat function, that might be one way to just get it across to the broader community. There is a question on the chat function from Dr. Rachel Chibanga. There's a compliment saying, great presentation, Dr. Chidziva and team. Could you please share what mechanism you have in place for providing hearing aids, especially to school children?
Am I muted?
We can hear you.
You can hear me. Okay, perfect. No, thanks. The privilege that we have, which has worked very well for us, is we have got a charity arm, Wizier Trust, or Wizier NGO, which raises not only awareness, but gets hearing aids for us. We were working at one point with Starkey, and another point with a whole lot of organizations which donate hearing aids to us through the Wizier Trust. And then when we go to the schools and we do our screenings, we're able to provide hearing aids either for free or for a very minimal amount, which seems to work very well.
Thanks very much. Dr. Sibere's email address is on the chat function. I'll just read it to people that aren't able to see the chat function. It's all lowercase. It's drzubair.ent1@gmail.com for anyone that's interested in a bit of an endoscopic outreach or assistance or some further information. I'm just going to ask Professor Fagan if he has any comments regarding this topic or any input.
Thank you very much, Clemence and your team. Clemence is really one of my heroes in Africa. I think what he's achieved is absolutely outstanding. He had the option of immigrating from Africa, but he stayed and he's worked under really hard circumstances, and he's been strategic. It's been a carefully planned program to build ENT audiology and speech services in Zimbabwe, and he's had tremendous success under very difficult circumstances. He worked for free at Harare Central Hospital for many years, which just shows this commitment that he's had to improving services in Africa. And we've had a wonderful collaboration with him, because we keep poaching all his best registrars or good registrars and training them, and certainly they have enriched our program here tremendously, and we've got friendships which are really so important across Africa. So Clemence, I'd just like to compliment you and your team, and we'll certainly be there to try and support you going forward. But thank you very much for all the hard work that you've done and your achievements that you've actually made.
Thank you so much, Professor Fagan. Prof. Pierre has just posted saying if anyone is interested in knowing more about PENTAFRICA, there is a website you can visit at www.pentafrica.com. I don't see any more questions or any hands raised on the floor. So if there are no further questions, perhaps we can ask Clemence, would you mind to close for us, you or your team, would you mind to any final remarks just to close the meeting?
No, thank you so much. Like I said, it has been a journey, a very interesting journey, full of opportunities. I think if we continue to open up these platforms for collaboration, we will be able to achieve a lot more. The collaboration between Zimbabwe and South Africa is very strong, the one between Zimbabwe and the UCT, but also the opening up of the region. I think that South Africa has got a lot to offer to the region. So that's why we are excited now that Jessica is with us on the ENT Hearing Forum for the Southern African and Central African region, which is a very active group and very well recognized by the WHO, for example. And I just hope those platforms will help us to collaborate and increase our training and capacity development. I also hope that in terms of training, we are pushing ahead for regional training through COSESCA, which is the regional training program for surgeons primarily. We hope that that expansion will allow many other countries who are unable to run MMed programs, for example, to get more and more specialists in the fray, and we'll be able to have a bigger impact. So thank you very much for the opportunity, and we look forward to further collaborations. Thank you.
Thank you very much, everyone. Thank you to everyone for participating, for taking the time to join our meeting. Clemence and your team, has been an absolute pleasure to host you. We look forward to hosting you again and to hear further success stories. I don't see any more questions or comments in the chat function or raised hands. So I think that we will proceed to close the meeting. We'll look forward to seeing you next week. We'll send out a link the day before the meeting usually. Yes, thank you all for participating. I'm going to end the meeting.